it's important to understand what you are doing. There are so many things going on, so many things that are proposed. You can easily get confused and carried away. But if you have some basic understanding what goes on, that gives you guidelines, it gives you understanding. And in that respect, I'm fascinating that here this academy tries to provide you with these basic essential information. And I'm sure when you listen to them, you understand those informations, it will be much easier for you to find your way in what you are doing. And as it was just said, if you know the background, of things that are conveyed, if you know the personal background sometimes of the authors, it gives you a totally different view about things, and it will certainly help you for the future to evaluate information that is thrown at you, and that will clarify the situation. Yeah, as it was said, I'm completely from a different world, unfortunately. I'm a neurologist, and so I'm neither a basic scientist nor an aesthetic doctor. But what we have been doing indeed over the last 30 years or so is that we try to explore the therapeutic use of botulinum toxin in many fields, mainly in neurology, but also in fields that are traditionally not considered to be a neurological discipline. And I will explain to you later why I think what we are doing in neurology can help you as well, because in a way we are pushing things to the limit. When you are talking about 8 units, we are talking about 1,500 units. When you talk about single injections, we talk about 30 years of continuous injections in patients. So in a way, what we have been doing is a sort of intensified version of what you usually do, and that experience we gathered from these extreme situations will certainly help you to find your way. So don't want to go into details. We cover the whole north of Germany from Hannover with movement disorders. So we are right in the center. That's the medical school. I must say we are not only doing botulinum toxin, and I think that's also important for you. As aesthetic doctors, you should not only do botulinum toxin. Botulinum toxin is very important, but you can intensify those effects with other methods like with fillers. In our case, we combine oral medications, we combine surgery with botulinum toxin. So please, that is one of the advice I can give you. Don't see single methods, see the problems, see different methods available, and try to combine them. That will certainly enhance your effects. That's a bit an overview about how we are structuralized, what we are doing, the staff, never enough. And that's a brief overview about our personal experience and my personal experience. When you talk about therapeutic indications in the rough area of neurology, we first speak about dystonia, explain to you later on what that is, spasticity, cerebral palsy, children's movement disorders. Recently, chronic migraine was also invented. Clearly, that's not a movement disorder, but it's as a pain condition part of neurology. But we got fascinated about the high efficiency of botulinum toxin in that indication. We have some rarer forms of muscle hyperactivity, and we have hyperhidrosis. I know a lot of you will probably come from dermatology, so you're aware of this problem. Perfect therapy for hyperhidrosis. I should have used it before I came here in this hot room. Axillary hyperhidrosis, but also different other forms. And some things that are a bit aside, tics, we try to explore the use, and tremor, and we even go to stump pain, rare pain conditions. And recently we published together with our psychiatric colleagues probable potential effects of botulinum toxin on depression. So you see how far that goes, but that will come in detail at the end of my presentation. Here, I mean, you can always have different ways how to measure what you're doing. This is just the sheer consumption of botulinum toxin vials, 100 mouse units, either Botox or Xeamine. So you see, when I started in 2008, end of 2008, how things have been taking off, and 16,000 or so. Now we are probably close to 18 or 20,000 units every year we are using. So that is quite a bit of experience we have gathered. So the lessons learned, the lessons we learned, and I would like to share with you is we are not talking only about motor indications. So what was discussed so far by Professor Pickett was mostly centered on motor indications. We have autonomic indications, I will mention that. We have more recently developed pain indications and experimental use. What I said before, we have this long-term observation. We have personally been treating patients since 1985, and I would say the oldest patient I'm continuously following up has started his therapy in the year of 1987, every 3 months coming back with medium range doses of about 200 mouse units. So we have this long-term observation, therapeutic efficacy, adverse effects, also immunogenicity. We have pushed limits towards maximal doses, and then we have been doing studies on systemic toxicity and antigenicity. And of course, we have some experience in handling the drug, like how to reconstitute, what modifications we can do, what are meaningful, what are stupid, what sort of basic documentation might be good. We have discussed legal issues, not necessarily that they were affecting us so much in therapeutics. I understand we are in a much better situation than you people in aesthetics. I think you have more patients that are willing to sue you. But still, we have also experience with this, and also depending on the country and depending on the medical system, we have some experience to handle reimbursement issues. So please feel free to ask these questions when you feel you should. I will just move things a little bit further now to the clinical scenario. What you heard from Professor Pickett was sheer heavy microbiology, molecular biology. So that is giving the foundation for more clinical pharmacology. Here I will discuss reconstitution, stability, therapeutic effects, adverse effects, long-term safety, antigenicity, and then I will open up the picture for you to see what can be done with botulinum toxin in fields that are further away from your experience. So reconstitution, we have touched upon this before. Of course, you are aware that all botulinum toxin type A drugs have to be reconstituted. They come as powders, lyophilized or freeze-dried powders. So before they can be injected, before they are activated, they need reconstitution. Toxin type B is ready-to-made liquid preparation. There are now discussions whether the toxin type A drugs should also be marketed as ready-made liquid preparations. We are just writing a review about that. In brief, I would say if you have already a conventional working type A product, it does not make any sense to register a liquid form out of that. That would require a full registration process with huge amounts of money involved. If you are thinking about completely new toxin type A drugs, maybe it's an alternative, but I'm not terribly convinced that liquid preparations as such are more helpful than than conventional preparations needing reconstitution. So the reconstitution is always performed with normal saline. That is what's given in the registration information and in the box inserts. However, when you go through the literature, you see that especially in the field of aesthetics, a lot of manipulations have been suggested. There are also reconstitutions where, apart from the normal saline, also local anesthetics are added. The rationale is that the local anesthetics should reduce injection site pain, but I think when you really logically try to analyze this proposal, it's ending up as other things that Professor Pickett has mentioned. Nothing is left. A local anesthetic cannot prevent injection site pain because it has to be injected firsthand, and so it doesn't make sense. However, we have analyzed reconstituted products also with local anesthetics. Local anesthetics in some cases have more neutral pH values, so that may actually really reduce injection site. But in principle, I would say local anesthetics, although it's done in various places, do not make any logical sense. The interesting thing is, and we were obviously the first who actually started this, when you look at the registration information, all the companies claim that the reconstituted botulinum toxin drugs have a neutral pH, which would be 7.5. But we were surprised when we measured that, that all of the reconstituted conventional drugs have acidic pH values going down to 6.0 and 6.5 sometimes. So that was really interesting to see. I don't know who suggested a neutral pH and how that came into the literature and came even into the registration process. That's clearly it's wrong information. And after many years ago, we had done a study comparing injection site pain between botulinum toxin type B and Botox as a conventional type A product. We saw that B had produced more injection site pain than Botox. We attributed that to the low pH the neuroblock has. So clearly, once we found out that the reconstituted drugs are acidic, we tried to reconstitute them with a neutral or more neutral buffer. And then when we tested that clinically, we could demonstrate that a more neutral buffer as a reconstituent produces less injection site pain. So in that case here, in that study, we used ringer acetate, which produces a pH of around 7.2 or 7.3 as compared to 6.5, 6.4. So if you want to improve reconstitution, I would say that using ringer acetate as a neutral buffer can be helpful, can make sense. In sensitive patients, we are doing this. Injection site pain is not a problem in all of the patients, but like in your case, when you're injecting facial structures, they are more pain sensitive. Then this pH normalization may be a smart and elegant way to reduce injection site pain. When we inject big limb muscles in spasticity patients, also injection site pain is not really an issue. Yeah, the second thing, when you reconstitute, you're adding volume, and the volume determines the the dilution of the product. And as it was discussed before, the dilution is having an effect on the diffusion. So the conventional thinking is the higher your dilution is, the higher your diffusion in the target tissue should be. So according to that argument, people are suggesting if you want to stay very focal with your injections, use high concentrations. If you want to have more tissue spread in your target tissues, then use higher dilutions. I'm not sure. There are not really good clinical data supporting this. In practical terms, our strategy is to use one dilution in order not to confuse the clinical situation, to make the handling more safe. We have a routine dilution, reconstitution process, so we try to keep parameters simple, standardized, and reproducible, so that mistakes can be avoided. The only time when we use high dilutions is when we want to cover large skin areas in, for example, axillary hyperhidrosis. Then we use a higher reconstitution volume, like 100 Botox units. We dilute then with 10 milliliters. But for all other muscular indications we are covering, we use 2.5 milliliters of normal saline for the reconstitution. Yeah, stability, that's something that is interesting. Stability for us is not so much an issue. You see how many vials we are using. We order new vials several times a week. They come fresh from the manufacturer. So for us, shelf life and stability is not an issue. Also, reconstituted drugs, the stability is not an issue because we use so much material. It comes in and goes out on the same day often. That's not the case. But in most of I would say, you use low doses. You do not necessarily have 50 patients every day. So you are wondering what's the stability of your unreconstituted or reconstituted drug. Unreconstituted, you were talking about the shelf life. But for the unreconstituted drug, the shelf life for all toxin type A products and type B also is in the order of several years. So I think at the moment for Xeomin it's something like 4 years, and Dysport should have 3 years. I think basically all these type A drugs in that freeze-dried or lyophilized preparation is very, very long. And if one substance and one product has a shorter shelf life, that doesn't mean anything. It just means that the companies didn't want to wait for 4 years to do the test. They wanted to get the product out on the market earlier. I think the stability is there even far beyond 4 years, and I don't think that there is any issue of differences between the stability. Anyway, it's so long that that's not clinically relevant. The reconstituted stability is a totally different issue. When you look on the registration paper, it said that once reconstituted, the drugs are stable for 1 to 2 days. They should be used after 1 or 2 days. That's clearly a very short period, and under the circumstances I mentioned, it may be a problem depending on the organizational structures of your clinics. So what we did is, and I must say others also have tried to cover that issue with different other methods. We tried to look for long-term stability of reconstituted drug. In this case, we used Xeomin. We haven't done the studies for other products. I don't know whether they would be different or not. But what we showed in continuous potency measurements using a mouse diaphragm assay, which is a very reproducible, very sensitive, and very well quality described potency test, we could demonstrate that even over a period of 1 year, there was no decline in potency of reconstituted xeomin in that case. So that means you can think about using the drug beyond that date of 2 days. If you want to share the vials, if you want to treat the same patient with the same vial after 4 months or after 6 months or after a year, the stability data would support you doing this. Whatever that means in your legal framework is something different. Whether your legal framework allows you to override or interpret the stability data from the manufacturers, I don't know. That is something you have to find out. One thing you have to consider is, and that's a study that's now ongoing, another reason to discard reconstituted drug after a certain period of time is biological, bacteriological safety. You have albumin in the vials. Theoretically, that could be housing bacterial growth. We do not believe this, but we want to produce, and we are in the process of doing this, we want to provide you with data showing once it's kept in a refrigeration, bacteriological safety also allows use of reconstituted drug far beyond that what's in the registration papers at the moment. Good. Let me move on to therapeutic effects. We have discussed really in great fascinating detail the effect of botulinum toxin on the cholinergic transmission. And what we have been, and we saw that the effects are absolutely highly specific. They're also fully reversible after several months of action. I must say that especially the issue of duration of effect of toxin in humans is not at all tested properly. We have a lot of studies where just patients are called in to get repeat injections after 3 months, but I'm actually not aware of a good study looking for how long a single injection is actually lasting on the human body, either clinically or with EMG studies or so. The actual duration of action of all toxin type A products or different toxin type A products or toxin type A products versus toxin type B products have not really been studied properly. Highly specific process, fully reversible. Time course we will discuss usually around 3 months. So far we have only talked about the cholinergic transmission towards muscle tissue. So the target tissue where we inject the toxin is muscle tissue. But there are also other structures that can be affected. Striate muscles, yes, we discussed that really, but also smooth muscles can be blocked by this blockade of the neuromuscular cholinergic synapse. But cholinergic synapses are also used to innervate exocrine glands, sweat glands, hyperhidrosis, saliva glands, hypersalivation, tear glands in ophthalmology. So those are the classical 2 areas for the toxin use therapeutically or aesthetically, muscles and glandular tissues. But recently, some 4 or 5 years ago, we also had to learn that structures involved in pain perception, transmission, or pain processing can be modified with botulinum toxin. The evidence for this came out of registration studies showing an effect of intramuscular injections in the cranial area to reduce chronic migraine. So we have now to keep in mind that beyond muscle tissues, exocrine glands, also pain structures can be modified. I'm very vague with pain structures because really there are no good solid hypothesis how toxin can modify chronic migraine. Yes, in principle we know that toxin can also target and block non-cholinergic synapses. Non-cholinergic synapses are involved in pain processing, but whether we are actually reaching those synapses when we inject the muscles in the head is something that's absolutely not known. There's a lot of discussion. The discussion is still open. All we can say, the double-blind placebo-controlled studies showed that chronic migraine gets substantially better when you inject cranial studies with botulinum toxin. So, okay, and for the time course, I said, effects kick in after 2-3 days. If you look in the EMG, you see probably effects as early as 1 day. The maximum effect is usually reached after 1 or 2 weeks. When it comes to certain pain elements in long-going dystonia patients, it can take several weeks before the pain is calming down. Those are secondary indirect effects, but on the neuromuscular junction, within a few days, you see that the effects are there. Effects are gradually wearing off. They last for something like 8 weeks. They seem to be similar in all target tissues. So whether you inject autonomic synapses like in hyperhidrosis or whether you inject muscular synapses, it's always in the area of 10, 12 weeks, 8 weeks, whatever. There is some ongoing discussion that in autonomic indications like hyperhidrosis the effect may be longer, but the evidence is not really necessarily convincing. The effect wears off very gradually. We have done really a lot of profiles in patients with diaries, daily diaries, when they are measuring their therapeutic efficacy, and you see then after this plateau phase over several weeks, the effect gets weaker and weaker, and so on. Interesting, it's the absolutely high reproducibility of the effect, which is for me biologically still fascinating. You're exposing the system repeatedly with the same intervention and the system is not responding to that. All I know from all my other studies, if you're exposing a biological system, the system as such responds. It either is prepared, so prevents the toxin effect, makes the effect shorter, or it loses efficacy over the time. But interestingly here, and I think that's still one of the things that are not really understood, you can do repeatedly the injection and the system responds the same way 100 times over and over again. But it's good because that is what we really need for a predictable therapeutic effect. The effects are different between different patients, of course also between different indications, but even within indications between different patients, individual variability is there. But if you have a patient and you do the same what you do, you have very predictable duration of effects. They come back within a week each time, and so that is something that's plannable and that's good and stabilizing for the patient. We discussed already there's a dose-effect correlation. The more you give, the more effect you have. That's also very important for medical therapies. When we want to interfere with muscular systems like in cervical dystonia, we do not want to knock out muscles. We need residual function in muscles, so we have to control the effect potency. Some muscles heavily involved in dystonia should be calmed down substantially. Other muscles only partially involved in the pathological process needs a little bit of modulation. So this dose-effect correlation is very important, and it's, I think, one of the basic mechanisms why the therapy is working. If you have all or nothing response, it would not work in most of our clinical indications. There is a dose duration correlations, but that's only within certain margins. You cannot prolong the duration of effect by doubling or tripling the dose. There is a ceiling effect somewhere in the order of 12, 14, 16 weeks. But when you are using very low doses, you can be shorter than this effect. So when you have a very short effect, you can try to raise the dose by 50%, maybe 100% maximum, to normalize it to the usual 12, 14 weeks of duration. But the limit is really, this is a ceiling effect, and beyond 14 weeks you cannot force the duration by enormously raising the dose. So, yeah, adverse effects, that is something, as I said, you're probably more often exposed to legal issues, so you have to know what you're doing, you have to know what can go wrong. Adverse effects. First of all, the substance has an excellent safety profile. I'm coming out of psychiatry as well, and we use a lot of neurological drugs. None of those drugs has a similar side effect profile, a safety profile as botulinum. All much worse. You're flooding the system with the oral drug. You have effects in every part of the organism. Here you inject locally, the substance remains for most of it locally. So all the usual problems with absorption in the gastrointestinal tract, respiratory tract, or wherever, you do not have that. There is no systemic distribution, so most of the organs cannot be touched with the toxin, and the excretion is it's not performed in the usual way through the liver, the kidneys, or the GI tract. It is locally degraded with local enzymatic degradation. So all the usual bottlenecks where you can have adverse effects are just not existing in this drug. However, there are adverse effects. One adverse effect are the inherent adverse effects. As I said, if you inject the muscle, you weaken the muscle, and the more you give, the more the muscle is weakened. That is the therapeutic principle, but however, each muscle in the body has a physiological function. So there is an inherent negative effect you are producing. You cannot get rid of this. However, that therapeutic window is absolutely enormous. We have muscles like finger extensor muscles. A little bit of weakening to counteract spasticity produces paresis. So these muscles have a very narrow therapeutic windows. We have other muscles like hamstring muscles you can inject with robust doses, and there is no physiological impairment in those muscles unless you would go to extreme sports activities or such things like that. So those muscles would have a large therapeutic window. In exocrine glands, there is no inherent adverse effect. So when you inject the skin against sweating, the sweating is gone and the skin is intact. There is no dry skin, there are no ragats or whatever. That makes this very elegant. And so hypersalivation, you knock out the saliva gland completely. There are still saliva glands elsewhere in the mouth producing enough saliva, so dry mouth is not an inherent adverse effect when you inject exocrine glands or saliva glands. In pain, the same. The pain is gone, and there is no adverse effect on the pain, no overshoot effect, or no adjustment to the therapeutic effect, and with increased pain elsewhere or after a period of time. So inherent effects there in muscular tissue depending on the therapeutic window. There is local adverse effects. That's mainly here for muscle tissue injections. As we discussed, there is diffusion. The diffusion doesn't stop at the muscle. It can go beyond the sarcolemma and the muscle connective tissues. It can reach adjacent muscles. Those are local effects. For example, if you inject here very focally certain finger muscles, and in writer's cramp, for example, you want to inject just certain fascicles of the finger flexors, adjacent fascicles can easily be affected, and you have then paretic effects in non-target muscles. That's a typical local adverse effect. But that again depends on the anatomical area. You have that in orbicularis oculi injections for blepharospasm with double vision, rarely, or with ptosis, maybe 1 or 2% of the injections can have those local adverse effects. Then there is something which I think is new, and we have just proposed to talk about regional adverse effects. That is, for example, you are injecting neck muscles and the patient complains about double vision. We just recently had a patient with this. This is clearly not a local adverse effect because the distance from the neck muscles to the external eye muscles is too huge to assume a diffusion process in adjacent tissues. The question is that caused by some systemic spread reaching very sensitive muscles, that a patient had a latent strabismus, so that external eye muscle that was affected by the injection was inherently affected before. In other patients we had myasthenia gravis, where external eye muscles were subclinically affected by myasthenia gravis, and then this potential systemic spread made those muscles clinically apparent. The other interesting thing is something, it could come from retrograde axonal transport into the spinal cord or the brainstem, and from there a diffusion or a transport into motor nuclei close by. Those are the two alternatives. Which one is true is a big question, but I think regional adverse effects have to be seen separately from local ones and systemic ones. Systemic adverse effects, that would require a systemic spread. This systemic spread is there. I fully agree with Professor Pickett. We do not know much really about how the toxin travels through the organism. We have animal studies, we have some preliminary studies with radioactively marked toxin. There is some spread. We can see it in very sensitive neurophysiological jitter examinations in distant muscles. It was many years ago suggested that maybe 1% of the injected toxin goes systemically. We have data that it can accumulate in the liver or in the GI tract, but what it is doing there, we don't know. The important message is the systemic spread with toxin type A is only subclinically detectable. So we never see systemic effects even when we go to substantial doses. When you go to very high doses, very occasionally you can see residual urine when you inject something like 600 doses for spasticity. But we have published a few years ago a study looking for the safety of very high doses up to 1250 mouse units, and with toxin type A there was no detectable systemic adverse effects or systemic toxicity. For toxin type B, it's completely different with toxin type B, and that is one of the reasons why this drug is not used really anymore. You see very easily autonomic side effects. You see dryness of mouth, you see blurred vision, all indications of autonomic adverse effects. The reason for that is not so easy. We believe that toxin type B has different affinity to autonomic synapses and to motor synapses. Very low affinity, obviously, to motor synapses. That's why we need 20,000 units for a cervical dystonia. And with those doses, we see in at least half of the patients substantial dryness of mouth. All adverse effects are fully reversible. Usually they are fading away after 1 to 2 weeks. That's a good message. If somebody with blepharospasm has some mild double vision or extreme gaze to the lateral, then we can tell them in 2 weeks or so it will all be gone. Yeah, long-term safety, that's a short story. As I said, we have more than 30 years of global use. We have covered numerous indications, including very high doses. We have continuous use in most of the individual patients. So we have really very good long-term safety data, and so far there are no long-term safety issues. And I don't know, after 30 years in that situation, I would not expect anything to come up in the next 30 years or so. So we have excellent safety profile for acute application, and we have excellent safety profile for the long-term use of the botulinum toxins. A last issue I want to cover is antigenicity. We have discussed it's a protein. Proteins are antigenic. Antibodies can be formed against the neurotoxin, the biologically active component. They can also be formed about the complexing proteins. Those ones would be called neutralizing antibodies, so that means that the antibodies would interfere with the therapeutic activity of the drug. We can have non-neutralizing antibodies when they are interfering with the complexing proteins, as they have no biological function. For detection, it's important to distinguish between these two types of antibodies, because for our clinical analysis, we only want to look for the neutralizing antibodies. The risk for antibody formation depends on the dose. The higher the dose, the more likely antibody formation becomes. The injection interval, the shorter the interval between two subsequent injection series is, then the higher the risk becomes. It depends on the drug used, especially when you use toxin type B drugs, which we only have in the form of myoblock. There we have a high percentage of antibody formation, and most of those patients with this antibody formation have antibody titers, which are so high that the therapeutic effect is completely blocked. Another reason why we are not using toxin type B drugs. For toxin type A drugs, the antibody formation risk is low. Relevant antibody titers interfering with the therapeutic efficacy occurs maybe in 1 or 2 or 3% of the patients treated, depending on the indication, deciding on the dose that is used. I must say, after analyzing many patients with antibody formation, I must say the decisive factor is the individual reachability of the patient treated. We have seen relevant antibody titers in patients receiving single doses. We have seen relevant antibody titers in patients receiving small doses. We have seen patients receiving high doses with short intervals for many years, not responding with antibody formation. So like with allergies, your immune system is hyperactive. You need a little bit of toxin every once in a while, your immune system responds. You have inert immune systems, you can do whatever you want, you don't get a response. those experiences are mirroring experience of immunization experiments, trying to immunize soldiers against the biological warfare of botulinum toxin. So maybe for you, the interesting thing is that antibody formation, relevant antibody formation, can occur even in aesthetic applications with low doses and long intervals. We have published a series of patients where this had happened. So in exceptional cases, I think a therapeutic failure, even in aesthetic applications, can be caused by antibody formation. If you have such an exceptional patient, you can try to get quantitative antibody measurements. There are not many places around who do this, but it's possible. You just take a blood sample and go into a mouse diaphragm assay and measure whether this blood sample has protective antibody titers. Okay, in brief, I think we are almost running out of time. What else beyond aesthetic medicine? Recently, there was this cover here from the Time magazine. Botox, we have to cross this out, botulinum toxin. This is, as you know, just one brand name. Botulinum toxins are almost something like Swiss Army knives. You can use them for many different indications. And somebody said, well, to me it looks like 19th century patent drugs in the Wild West. You can have it against impotence, you can have it against headache, you can have it against hair loss, whatever. Here the thing is different. Here we have reasons, we have a clear mode of action why the substance can reach out into so many different medical areas. Keep in mind, we all owe this therapy to this man. That was the inventor of the therapeutic use of the toxin. He's still around, and every day he watches what's new and what new indications are coming up. This is a brief overview. The size of the box is a rough estimate about the relevance of the toxin, dash the amount of toxin sold in the different areas. It's very rough. We don't have good marketing figures, but that's, I think, more or less many people would agree. The largest indication is still in neurology. It's dystonia. It's this peculiar situation when muscles are spontaneously contracting and moving the head, moving the hand, moving the leg. An indication that was not treatable before. So toxin was the first time that those patients could be effectively treated. Now we can have also some brain surgery also helping them, but a lot of those patients after brain surgery still come back and receive a combination therapy with botulinum toxin. A huge indication in neurology is spasticity. You know, stroke produces contralateral paresis, but not only contralateral paresis, but also involuntary muscle activity. If you inject those muscles, they can be relaxed. Residual function can be set free. So it's very important indication for patients with spasticity. We have now chronic migraine covered in neurology. We have a lot of smaller indications. So I would still say that together with aesthetic medicine, neurology is the largest area where the toxin is used. Ophthalmology, that's how it all started. You saw Dr. Scott's picture. He was an ophthalmologist. He started in ophthalmology to treat strabismus in children. That's an indication that's nowadays not used very much anymore. Blepharospasm sometimes is treated in ophthalmology rather than in neurology. So ophthalmology is really relatively small. Urology, you have a lot of problems with the muscular control of your bladder, and you have paraparesis, or when you have brain damage, your muscular system in the bladder is not working properly, and you can modify the activity of the sphincter muscles blocking the urethral outflow, or you can modify the excretion muscle, the detrusor sphincter muscle, and then that can normalize muscular bladder dysfunction. Ear, nose, and throat, yes, that's not so much. We have hemifacial spasms and peripheral nerve irritations with blinking. You can inject there. We have some reinnervation problems after parotid gland operations when we have crocodile tears problems. So patients are producing tears when they eat. They have skin rash. You can treat that in ENT. Pediatrics is a relatively large indication. You have a lot of birth and intrauteral problems in children producing spasticity, dystonia, and when it occurs there in this young age group, they are clearly treated in pediatrics, so a lot of muscle spasms in pediatrics. Gastroenterology, you have some sphincteric muscles in the esophagus and the biliary tract. Endoscopically, you can inject them. Dermatology, of course, dermatology and aesthetic medicine is closely interacted. Dermatology in this case means hyperhidrosis. Aesthetic, you know better what you're doing there. Psychiatry, question mark, that's this study suggesting that the toxin can have an antidepressive effect. That's even more weird than in chronic migraine. The mechanisms involved here are completely speculative. Yeah, so in summary, botulinum toxin represents a completely novel therapeutic principle. It's something completely new. It can be used for conditions based upon muscle hyperactivity, exocrine gland hyperactivity, and pain. It has a complex and therefore fascinating mode of action. Its number of medications, of medical indications, is huge and still growing. For most of these indications, toxin has been the treatment or is the treatment of choice and has been really a revolution for the patients. The use of toxin in non-aesthetic indications provides an insight that's also for your work with toxin in aesthetics. Yeah, that's all I wanted to share with you. I kept with almost 1 hour a long talk.